Okay, good morning. We would like to welcome everybody in this early morning session, and as every hand surgeon probably knows, the issue preparing a tendon sometimes is very easy, sometimes it's very difficult, and when we look in a mirror, we all think that our results are the better, all others are not so good. But let's see what's the reality. Let's see how tendon repair changed during the last 100 years, and let's share our experience and the experience of the speakers, and let's have an interesting session. So I would like to invite the first speaker, Martin Langer, who will speak about the history of the tendon surgery and tendon rehabilitation.
Good morning, everybody. I'm very proud to talk here about the history of tendon surgery as a FESSH historian. And just waiting for the illustrations. And the history of tendon surgery begins very early in Greek mythology. And before Zeus was the greatest god of all, he had to fight against the Titans. And one of the Titans was Typhon, a monster with more than 100 heads. And during the fight, Typhon stole the diamond sickle from Zeus and cut the tendons out of his hands and feet and pulled it out of his body. The mighty god was powerless without tendons and sank to the ground. The monster Typhon brought Zeus into a cave in Sicilia and then went in search of a boulder to close the cave. And then, here you can see the first hand surgeon of the world and what a hand surgeon should be. Then came Hermes, the clever son of Zeus, who always knew a way out, like a hand surgeon, came to help his father. And he managed to steal the god's tendons and put them back into the hand and feet with great skill, like a hand surgeon, and patience. And Zeus had a very good rehabilitation in a very short time, and Zeus then plunged again on the monster. On Sicily, Zeus then threw 100 lightning bolts on the monster at once, burned all his heads, and rolled a mountain massif on the burning monster. The fire broke a path through the rock and broke out at the summit. And from the space you can see sometimes the still burning monster here. This was a history. History in Greek with Hippocrates. At that time, tendons and ligaments and nerves were all neuron. And we still have the term aponeurosis from that time. In Rome, Galen said nerves and ligaments that are dissected to refix is not possible. In 1,000 years ago, in Arabia, they tried to suture the tendon with a surrounding only by a suture of the surrounding tissue. And the first tendon ligament suture that you can find in the literature comes from Strasbourg from 1497 from Hieronymus Brunswick. He said, if a tendon is cut, then suture it with a waxed thread, it will not harm. 60 years later, Felix Wirtz also recommended tendon suture. And here is Matthäus Purman, and in 1699 he was a world champion of tendon suture. He had 12 successful cases. And it was here, not far away from Berlin. In 17, in Paris, Pierre Dionny showed this technique of tendon suture. And in 1728, here in Germany, to have not a tear out of the thread, Lorenz Heister used a leather on the right and parchment on the other side of the tendon suture. Everything changed after the year 1867 by Joseph Lister, and 200 kilometers in the north of Berlin, in Rostock, Franz Koenig did the first tendon suture under listless antiseptic conditions. It was an extended tendon. But here you can see Bernhard von Langenbeck, the founder of the greatest dynasty of surgeons here in Europe. His tendon technique in 1878. Then Carl Nicola Doni from Vienna showed this fundamental techniques of tendon suture, and Vienna was a great place for tendon suture. You can see here Anton Wölfer in 1888, and here is a Banel type of tendon suture, and the Schüssler in 1819 from Vienna showed this technique before. The single sutures had the last days with Banel in 1918, and they said it's not useful. And we have thread-thread connections since 1893. We have multiple ribs since 1907 by Otto von Frisch from Vienna. And punctural anchors of the suture material in 1905 by Anton Eiselsberg from Vienna. And here, multiple strands. And this technique by Ludwig Kirchmeier from Vienna was the main technique for, I think, for nearly 100 years and until today. And here are the variations of the Kirchmeier technique you can see here. And here in a shortcut, you can see how it works. You can close and have this tendon suture. A modern 6-strand suture goes like this, where you can close the gap and suture it. Loop stitches, like the Zuge, everyone knows Zuge, you can find first in 1919 by Müller. And here are so many techniques, and I found in the literature more than 107 core suture techniques until today. And also the preferential suture techniques you can find here are variable. And then we go to hand therapy. The results of flexor tendon surgery in the beginning were like this, without antibiotics, and you had stiff fingers, and so the treatment in hand therapy was against the contractures. You can see here in 1880 Reibmeyer's apparatus, and here in 1895 from Thilo, and here also from Berlin, Franz Schede showed these techniques to have machines against and splints against the contractures. Here it's from Budapest in 1917, a simple technique to have extension and flexor on the fingers by a little bit more power. And here are apparatus that you can't find today in the literature, but sometimes they are very good ideas. And they had a lot of work to work against the contractures. Here in Berlin, Friedrich Mommsen was also very famous in the clinic of Biesalski, and he was the first who showed the power of the small forces. The power of the small forces comes here from Berlin, from Mommsen. And in 1910, Eduard Rehn and Alexa had experiments on the tendon sutures, and they found out that through an early functional exercise treatment, not only a firm connection with the tendon at the rupture area, but also a regeneration of the underlying fibers occurs. At the same time, the early movement avoids an adhesion of the gliding tendon to the neighborhood. That was 1910. And we missed something because Sterling Bonnell said here is a no man's net, no one should try to suture, and it's better to remove the tendons entirely from the finger and graft a new tendon throughout its length. And this is the result of flexor tendon surgery in 1955 for zone 2. It's a study from Scandinavia, 1% good, 99% nearly bad. And then came in 1967 the hand therapy, and that's the result of hand therapy in tendon surgery. Yeah, there are many, many programs today that we can use, and we are on the shoulders of giants. Thank you very much.
Martin, thank you very much for that historical review. That was interesting. And I would actually like to ask the next speaker, Jason Wong from the United Kingdom, to give us the background information on tendon healing and suture biology. Jason.
Thank you. Thank you, Mr. Speaker. It's a great honor to be speaking on this podium with such esteemed colleagues. I'm going to give you a biology lesson this morning, so please feel free to listen. The kind of key structural considerations that we have when we're doing flexor tendon repairs is that the anatomy is fairly constrained in the no man's land area, where you've got a firm fibroosseous sheath and you have two tendons gliding within this space. And it's that space that's actually the key to understanding how you get good results. And the other thing about the sheath space is that there's huge amounts of vascular tissue around that pulley structure that actually provides nutrition to that intrasynovial space, but also provides a highly vascular environment after injury. And the hand is an incredibly vascular structure, and we often forget that because we're operating on it when we have a tourniquet on. And actually, if you look in the zone 2 area, you've got the short and long vincula there that are actually susceptible to injury during that time. And it used to be thought that if you damage the vincula, you'd make the tendons ischemic and you get poorer healing. But in actual fact, what tends to happen is once you take your tourniquet down, if you've divided your vincula, you'll get bleeding into the intrasynovial space. And that blood is the substrate for scar. And we've known about that for some time. So in different positions of laceration, you'll find that you are more or less likely to divide the vincula and create this highly coagulative environment. The other thing about tendon is that it has a skin. So there's a very fine layer that we've historically known as the epitenon, but it's got this distinct skin anatomy. There's a number of junctional compounds that link all that surface together. And when you disrupt that, the cells aren't very bright. They see that the fence is down and they start escaping and migrating to other parts of the hand. And I'll show how that occurs. The key thing to understand about injury is the mechanism of injury is very different and dictates the outcomes. So a simple laceration will have a different outcome to a severe crush or an avulsion injury. And effectively, we know this in lower limb, that the kind of injury dictates the zone of trauma. And this is what's called a live-dead assay. The cells that are green are living, the cells that are red are dead. And different types of injury create a different pattern of cell death. So if you look at the suture, around the suture, where you put your needle through, you'll get this zone of death around the suture. If you scrape the surface or you handle the tendon with a pair of forceps, that will kill the tendon. But if you transmit high force and you avulse the tendon, and you see this in Achilles tendon ruptures, you'll get huge amounts of cell death. And suturing that tendon will be very different from other standard types of repair. Strickland's reviewed the various different types, the pattern of tendon healing, and it basically follows the same paradigm as wound healing. So there's the inflammatory phase, the synthetic phase, and the remodeling phase. And they kind of allow us to dictate when we start our different therapy regimes. There are a number of outdated, I would say, concepts that relate to tendon healing, and those talk about the extrinsic and intrinsic types of healing. But effectively, when you get a laceration to skin, the first thing you see is activity within the skin and cells migrating towards the tendon and trying to get it to heal, and that was the original extrinsic theory. Later work by my mentor Gus McGrowther showed that the surface cells actually contribute quite a lot to the healing of the tendon, and they start to migrate into the tendon substance. So this is just a small laceration on the surface of tendon, and what you're seeing here is the cells within the tendon filling up that space. So that's what will happen in an organ culture. But the cells have that wire mesh, if you like, that barrier disrupted. So the cells begin to migrate and just follow a growth factor gradient into the surrounding tissue. And you see that the surface of the tendon, they actually begins to thicken. And those are the fluorescent images at the bottom. They thicken up, so you get this thickened epitenon within this tight space. And the cells begin to drill down into the tendon substance. And they're all triggered by the usual growth factors, and James Chang, who's in the audience, has looked into some of these. And this is cell mapping, looking at how the adhesions form. So you've got the tendon on the top, and you've got the subcutaneous tissue and skin at the bottom, and you've seen the knife go through. What you get is the subcutaneous tissue and skin swells, and that's what you see as your edema, and the inflammatory cells migrate in through the subcutaneous tissues towards the site of injury. As you get swelling of the soft tissues and swelling of the tendon, you get this interface, and if you don't move that interface and you've got a substrate of clot everywhere, then everything gets stuck down. And the green cells are basically cells that are producing new collagen in that environment. Macrophages are coming in, and cells are following that injury signal, causing adhesions to form between the tendon and the subcutaneous tissues. And then over time, over probably about 4 weeks, that reaction begins to dampen down. So over the course of about 8 weeks, those adhesions get thinner and thinner, the fingers swelling becomes less and less, and effectively you get resolution of that healing process. So the whole process lasts probably about 8 to 9 weeks. And it's that overlapping synthetic phase between the soft tissues and the tendon that allows the adhesions to form. So in order to beat adhesion biology, what you've got to do is minimize your soft tissue access, minimize any unnecessary iatrogenic trauma, meticulous hemostasis, and try in any way you can to reduce the edema and obviously get the fingers moving as quickly as possible, possibly with intraoperative movement. And the more developed our suture technologies become, the more aggressive we're managing to get these tendons moving, the better the results we're seeing. The mobilization reduces scientifically adhesion formation, reduces inflammation, changes the diameter of the fibrils that are in the collagen, and also increases strength of repair. So apart from adhesions, we also look at ruptures, and the rupture rates are coming down, and this graph shows that the number of parameters that reduce your rupture rates. The material influences the strength of your repair, the gauge of the suture influences your repair, the number of strands, but actually one of the biggest determinants is the size of your bite. So the bigger the bite that you produce, the stronger the repair you'll get. In terms of the biology, that when you suture a tendon, what you see is these acellular zones forming where you grasp the tendon. And if you put these under tension, you'll get this zone of cell death. So all sutures create some death as a result of putting them in place. And the reason for that is when you put a suture in, you get this area of high stress. This is acoustic force microscopy, and it looks at strain. So the red area demonstrates that you're straining tendon every time you suture it. And if you mobilize it, you'll get adhesions forming. So this is just the biology of suturing tendon. You put a suture in, you grasp, the cells basically die off, and you create this zone of cell death. And then all that inflammatory tissue all that subcutaneous tissue becomes really inflamed around it. And you get this persistent inflammatory zone around the tendon. So all these cells are basically trying to munch their way and making your tendon softer. And this inflammatory process actually lasts quite a long time. So we've got to find a way to replace sutures. So how do we beat the suture biology? I think we need to suture less and suture smart. We have to minimize the soft tissue trauma once again. And we've got to think about how we distribute load across a larger surface area and use sutures that do less damage. Also, taking big bites away from where your tendon needs to heal is kind of key to beating that cell death. So in summary, tendon injury dictates the tendon healing response. The tendon healing follows a wound healing paradigm, overlapping over a number of different tissues, and adhesions arise through overlapping tendon and sheath dynamics. And suturing of a tendon gives rise to weakening. Okay, thank you very much.
Thank you very much for this very interesting and very nicely documented presentation. And we realize that biology has not changed in the last 10,000 years, but let's see what changed in surgery. So I would like Don Lalonde to speak about what changed in hand surgery in tendon repair.
Thank you. There is a wide awake hand surgery book, including in Chinese, and there's a Wallant website, but I make no money on these things. A lot has changed in flexor tendon repair in the last 19 years. In a clean-cut flexor tendon in a cooperative patient, we should get a good result with no rupture and no tenolysis almost every time, like in free flap surgery. Forget the old don't vent A2 or A4 rule. The new rule, never vent more than up to 1.5 to 2 centimeters of pulley. This will avoid clinically significant bowstringing. Here you see me divide A4. And after I do that, I put in a core suture and see what structures are stopping my tendon from gliding. In this case, I can see that a little cruciate suture is stopping the tendon from gliding. So I divide that right there, and I leave A3 alone. You just incrementally divide just what you need, no more. And you don't see clinically significant bowstringing on the table, and you don't see clinically significant bowstringing after the surgery. The old A2, A4 pulley rule gave us 50 years of unnecessary rupture and tenolysis. Today, a good repair is a 10 to 30% bulky, solid repair with big bites that easily fits through up to 1.5 to 2 centimeters of vented pulley. If you only vent 1.5 to 2 centimeters, you never vent both A2 and A4. Even if you vent a lot of A2, and Dr. Maria from Japan has shown us that that's okay, you still have A1 and A3 intact. And it's 1.5 to 2 centimeters because some people have short, fat fingers like I do, and other people have long, skinny fingers. I used to think that the repair on the right was a good repair. That's a grandma kiss repair. It's not a good repair. You know, when you kiss your grandmother, you go on the cheek, and the tendons are just kissing. We used to think that what grandma kiss repairs were good because we had to fit through the pulleys. This patient has just had her FPL repaired, and she's got a grandma kiss repair. See, it looks pretty good, right? Looks good until you stress it. Watch what happens when you stress it. There's the gap. The tendon is bunching in the suture. The active forces of movement cause a gap that would have gone on to rupture. But because she's awake, I saw the gap, fixed it, and she did not go on to rupture. So this is the cause of a rupture. It's not all about the holy grail of 1,000 different sutures that Martin showed us. That grandma kiss rupture happens 7% of the time when people have a motor block or when they're asleep. We know that from a series of over 100 tendons that we published 9 years ago. And all of the tendons that gapped were grandma kiss repairs. That's why we've moved to Jinbo Tang's bulky repair. Wallant full fist flexion and extension testing allows us to repair gaps to avoid rupture, allows us to vent pulleys to avoid tenolysis. And Wallant has also taught us a lot about therapy. Look at that beautiful tendon gliding with true active movement, the way it should be, flexing at the DIP first. And now look what happens when we simulate full fist place and hold. The tendon moves, and there it stops. And now it's buckling. It's not gliding anymore. And when I ask the patient to hold it, it jerks right there. I'm going to show you that again. Full fist place and hold, you passively move it. We always thought it kept moving. It doesn't keep moving. It buckles, and then hold it, jerks right there. On the left, passive movement, it's not moving. It's stopped gliding, it's buckling, and hold it, jerk. In the middle, passively move it, it stops moving, it's buckling, but when we ask the patient to hold it, jerk. And on the right, same thing. Passively move it, it stops moving right there. Get in a little closer to see it, hold it, and jerk. Wallant has taught us we only need half a fist of true active movement to get 5 to 15 millimeters of profundus glide. That's all we need. We don't need any more than that. We just need to keep it moving so it doesn't get stuck. The highest work of flexion, the highest friction is in the last half of a fist, especially the last third. That's where the risk of rupture is highest. Can we have the sound, please? We need sound with this video. Hello, sound. I'm so sorry about that. Anyway, if you could hear me, I'm explaining to the patient that this tendon repair is going to be weak, that a suture is only 1/10 the strength of a normal tendon, that he's going to be able to move it, but he can't use it. You can use this opportunity during surgery to teach a patient instead of talking to the nurses about the weather. One of my favorite questions for these patients is, so, what were you planning to do this week? Because inevitably, whatever they were planning to do is not going to happen. They're not going to be taking that golf trip and golf. They're not going to be swimming with their kids at Disney World. And so all these patients have to say 3 times, I can move it, but I can't use it. I can move it, but I can't use it. I can move it, but I can't use it. Intraoperative education is the time when you have their absolute attention. They have nothing else to do but pay attention to you. And this is how you prevent rupture. This is how you prevent hematomas, by telling them to keep their hand up. This is how you prevent complications. This man had an extensor leg at week 8, and we put him in a relative motion flexion splint, which drives extension to the PIP joint. 2 weeks later, he gained 20 degrees of active extension. Patients exercise while they're living with relative motion splints. They don't stop living to exercise. Thank you for that, Gwen Van Strien. This patient was doing great at 2 weeks. He had lovely gliding, everything was fine, and then at 4 weeks he got stuck, stopped moving. We did the ultrasound in the clinic. It's not ruptured, it's just stuck in scar. So we started relative motion extension splinting. Everybody please take a pen from your pocket and just do this and do this. I want you to look at what's happening to your long finger. You're forcing it to flex more. You're pulling profundus out of scar. Here he is 8 weeks after the repair and 4 weeks after relative motion splinting. When your patients are stuck in scar, don't do tenolysis. Put them in a relative motion extension splint to help break up the scar. In summary, the 7 most important things to consistently get good results with clean-cut repairs are, number 1, at least 4 strands of very solid repair with 1 centimeter bites, just like Jason just said. A bulky repair. Judiciously vent up to 1.5 to 2 centimeters of pulleys. Intraoperative active full fist flexion and extension testing. Intraoperative patient education is one of the most important things. Up to half a fist of true active movement post-op, not place and hold. And relative motion splints to improve flexor and extensor lag. I'd like to thank Dr. Jinbo Tang, who's taught me a great deal and helped me move into true active movement away from full fist place and hold, helped me vent my pulleys, and helped me do bulky tendon repairs. And I'd also like to thank Amanda Higgins, my fabulous hand therapist, for helping my patients every day, and also for writing up the flexor tendon St. John protocol, which is almost identical to Dr. Jinbo Tang's paper from 2017. This paper from Jinbo Tang in 2017, I think, is just as important as Kleinart's 1967 paper when he said we should do early protected movement. If you haven't read Jinbo Tang's 2017 paper, for the sake of your patients, please do. Thank you.
Thank you. Thank you, Dr. Lalonde. And I'm now looking forward to listen to James Chung from the United States, as he's going to give us some introspective in different kinds to teach and to learn suture techniques. Dr. Chung.
Thank you, Jorg. My task is to show everyone how to learn, but really how to teach tendon repair, flexor tendon repair, because in the 2 hours of this session, as we argue and discuss the details of our techniques, thousands of flexor tendons are being repaired around the world. Probably not as good as the way Dr. Lalonde or Dr. Merritt would do it. So our job is to teach the world. My university is in the heart of Silicon Valley, home of Apple, Google, and Facebook. So you may think I'm going to be talking about augmented reality, artificial intelligence, laser-guided flexor tendon repair simulation. Well, I'm not. Why? Because complex simulation is not necessary. After all we're doing is putting 2 ends of a rope together. However, this is a complex task. It has to be tactile. We need to feel the material. We have to be able to teach on the same material, just like making a fine Italian suit. And I would say that in order to get this flexor tendon to glide properly in a 21-year-old athlete, that we have to be as good as an Italian tailor. So here are the challenges. Flexor tendons are hard to sew. The access is limited, the anatomy is unforgiving, as Jason Wong has showed us, and the rope frays. And the goal of a gliding tendon is difficult to achieve. That's why we're all here at 8 in the morning. The additional challenges are flexor tendon injuries are episodic. It's not carpal tunnel, it's not trigger finger. We don't have hundreds and hundreds of these, so they're episodic. A trainee may see some on rotation, but then may rotate off. And I would say that most repairs, 99%, are not done by the people in this room. They're not done by expert surgeons. They're done by general surgeons, orthopedic surgeons, and plastic surgeons. And as Jason and Martin Langer have shown us, there's so many different repair techniques. This is really confusing to the trainee. In fact, I've asked our Stanford trainees just last week to draw their repair. I teach the same repair over and over, and you can see all the different variations of that repair. So the key is to teach a flexor tendon repair technique that everyone can learn and use everywhere in the world. And find that technique that makes you personally satisfied, and then teach it, use it, and share it. There are 5 sequential steps to this, and I want to focus on the 2 key intervention points, numbers 2 and 3. Number 1, you have to start with the book. You have to learn the principles. You have to learn the issues and the anatomy of flexor tendon issues. Second, I'll show you how to suture in very easy models that anyone can do. Third, you have to use tendon material. You need that same bolt of cloth you'd use in tailoring. You need to feel the material of how a tendon reacts to the suture. Fourth, you have to then go to the cadaver lab and see how the tendons interact, how the FDS wraps around the FDP. And lastly, you have to do it in patients. So I'll take you through these 5 steps. First, Jason and Don have talked about all of these principles. All of these issues are important, and so you have to put together a very tight curriculum on how to deliver that message to not just a hand surgeon, but the orthopedic surgeon, the general surgeon, and the plastic surgeon. Second, and I'll stop here and focus a little bit, you have to teach how to suture in an easy model. The first time a trainee learns how to sew a flexor tendon shouldn't be during a replantation at 2 in the morning on a patient. It should be done on this. And try going down the hallway in the operating room to the oral and maxillofacial surgeons. Take some dental roll, just a tight cotton web, and also take a straight needle. You can take these, put them in your pocket, and take them back to the office. I show our therapists how to do the repair. I show our trainees how to do the repair with a simple straight needle. And you can sew, and you can do this without any cadaver, without any fancy material. And what do you teach at this step? You teach what an epitendinous suture is. You teach what an actual core suture technique is like. You teach that 4 strands or more is critical. And you teach, as Don said, that a centimeter at least of purchase is necessary, and how to prevent gap formation. This is done without a cadaver, just on simple dental roll. But we teach this over and over, and I would say our therapists really value seeing what these types of repairs are like. The third step is to suture on real tendon tissue. I have 18 residents. I don't need a hand for each resident. I just need 1 hand at this instance, because you can take that tendon, divide it into short segments, but still have the residents and trainees learn what it is like to put a needle through a frayed rope. And what do you learn at this stage? We can advance the next slide there. Oh, we'll go back 1. Can you go back 1? Oh, that must be the one, okay. We can go to the next slide. Try to advance to the next slide. I'll do that. Okay, thank you. Just going back to this slide, you can see one way we had to encourage residents. It's a little box of chocolate next to the tendon repair site there. But I teach an epitendinous first technique. Beautiful different repairs are available. I'm a tailor. I like to tighten the epitenon first and then put into 2 core sutures. It really doesn't matter. We're not here to quibble about the type. It works for me. I love what Don Lalonde does also. I love what Jimbo Tang does. Find the technique that works best for you. But in this step 3 on tendon tissue, preferably human, but it could be pig or some other tissue, you learn how to gently handle the tendon. You learn how to push the needle through tendon tissue. You learn how to match the ends perfectly, what a grasping technique is versus a locking technique, and how to avoid fraying the tendon. All of it is done in the safe environment of a library without a large cadaver. This is important because you have to teach this curriculum. We wrote this paper a few years ago about overcoming the learning curve, and you can see on the 2 bar sets to the left there, that is before the tutorial. The tutorial is simply the tight curriculum that we've shown all those principles of tendon repair, and then having them do a repair on the human tendon tissue, and then afterwards, that they're able to achieve a strong repair in our trainees. And the education stays. We retested these residents 6 months later, and by teaching a simple repair on tendon tissue, that they can go out and practice and continue to have those strong repairs. Step 4 is you do have to go to the cadaver lab. Before operating on a patient, you do need to see this, and there's no way we can simulate how the FDS beautifully wraps around the FDP and how it's so tight in zone 2, and how to recreate the curve of the tendon of the FDS as it wraps around the FDP and inserts 180 degrees around. We need to show that in a cadaver, and we need to show how to access and suture. So in step 4, in the human cadaver, the key points are how to access the tendon, which pulleys to release or vent, and I completely agree with Don that we're more aggressive about venting than before. How to retrieve tendons. Gus McGrath taught us novel tricks of how to pull that tendon out of the palm effectively. How the FDS and the FDP orient themselves, and also where to leave the knots away from the pulleys. And the last step is step 5. By now, your trainees have learned all of these things from the textbook to the dental roll, to the human tendon, to the cadaver, and now they're ready to operate on patients. And you can see here in a typical case in the operating room, the key things to discuss at that point are how to explore the entire tendon, how to manage nerve and artery injuries, how to talk to the patient during surgery with wide-awake technique, and the rehabilitation protocols and when to do a tenolysis. So those are the 5 steps. I will concentrate on those 2 steps, easy models and tendon tissue as prerequisites before the cadaver and humans. Thank you very much.
Thank you. And now I will ask to Gwendoline van Strien from Netherlands to speak something about the early active flexor tendon rehabilitation, how therapy changed based on evidences.
Thank you very much. I'm going to talk about early active motion for flexor tendon rehabilitation based on the evidence. First, I'm going to talk about wound healing and sutures. And as Dr. Wang already showed you, there has been a paradigm shift in wound healing. The tendon healing apparently starts 2 weeks after the surrounding tissues have already started to heal. And the tendon only catches up after 21 days, when the surrounding tissues are probably already quite done. So basically, the adhesions are formed early, and we should move early to prevent these from blocking the tendon to move. But we can only move early if we have a strong suture, because otherwise there would be ruptures, as the tendon is healing so much slower. Now, what we know about adhesions and ruptures. In the systematic review by Starr in 2013, the early active motion showed the same rate of rupture as the Kleiner-Durand types, which is early passive motion. But the lack of glide had a significant difference, and that lack of glide is the adhesions that are forming, and they need tenolysis. And I would like to make a point that we should report in our articles that a tenolysis is just as much a failed result as a rupture, so we should put them next to each other, because they both really need secondary surgery, so they're both a failed result. Now, what do we know about suture strength and early active motion? Is it safe to do? From this article by Rawson et al. In 2013, we can see that if you increase the amount of core sutures, the increase of strength and improved gapping resistance is right there. But we also have increased gliding resistance, which is probably a problem for functioning of the tendon. What we know about suture strength is coming a lot from the articles by Kursa and Etzfeld. We know a 4-strand suture can be loaded to 40 newtons, but the maximum load on a profundus is under 20 newtons, and for the FDS is even under 15 newtons. Note that one subject actually did exceed the 40 newtons, but the wrist was in flexion at the time. But we have to remember that these studies were done on normal tendons, not repaired tendons, and a full fist was used. And we don't regularly use a full fist. We use half a fist, as is recommended for early active motion. Now we want to talk about optimal glide and work of flexion again. Amadio defined the friction and the resistance as work of flexion. This friction is defined as the force needed to overcome any resistance to glide and make a fist. So, what are the variables to consider? The internal work of flexion is the glide resistance between tendon and sheath when the tendon is swollen. We also have extrinsic work of flexion factors, edema and stiff joints. You have to pull harder to pull a stiff joint into flexion, and the resistance of the antagonist if you go into a flexed position. Now, these all will affect our clinical decision making, so they are important. Is there any evidence? Well, the relationship between edema and work of flexion was seen by Yi Chao and Tang in 2005. As the edema gets more severe, the work of flexion goes up, and we see the work of flexion increase. There it is. They also Wu and Tang looked at the stiffness, and the results from this study was that if there were stiff joints, the work of flexion was significantly higher. And if you did repeated passive motion, it would reduce the work of flexion. In fact, if you did 6 passive motions before you move actively, it would reduce the work of flexion significantly, which is fine for therapists to know because this is our exercise routine. Now, the positioning of the wrist is compared in the article by Kursa and Etzfeld and by Savage. If you put the wrist in neutral or 30 degrees of flexion, does it increase or decrease the work of flexion? If the wrist is in 30 degrees of flexion, it turned out to be, for all 3 articles, that there was a significant increase of the work of flexion. For the MCP joints, if you put the wrist in neutral, the profundus actually had its lowest work of flexion at 15 degrees, and it would increase from 45 to 60 degrees. For the FDS, it didn't make that much of a difference if the wrist is in neutral. However, if you put the wrist in flexion, there is a significant increase of work of flexion going from 45 MP joint flexion to 60 if you're in the splint. So the best position would be between 15 and 45. So summarizing this, the wrist should be in neutral or slight extension, and if the patient is reliable, you could put the wrist free, and Zoe Clift is one of the next speakers who's going to present that splint. The MCP joints should be in 15 to 45, and the PIP and DIP joints, I want to put this here again and again, they should be absolutely straight in the splint because we do not want to have flexion contractures. If we're going to look at early active motion, work of flexion, and the position of the fingers when we're moving, Tang did 2 papers, 2003 and 2007, that showed that the least resistance, and Dr. Lalonde already mentioned this, in the first part of flexion, the first third of flexion. In the mid and final third of flexion, you get a higher work of flexion. So we really should not do more than 1/3 flexion up to week 3, and we really should never push for full flexion in the first 4 weeks of therapy. Now, he also looked at the pulleys. And if you look at the yellow bars and the green bars, the yellow bars is when the pulleys are intact. The green bars is when the pulleys are released. And more tendons survived when the pulleys were released. So there's less friction. It makes a case for pulley venting. Now that gives a risk. We think about bowstringing, and that would be somewhat of a danger, you would think. But Reisner in 2018 showed that with a 6-strand core repair, partial complete division of the pulleys, tendons checks after a year, 12 months, that there was no notable tendon bowstringing clinically and only minor bowstringing on the sonographic evidence. Now, this is all great and very surprising to me, but we do need more research. It's only 1 article, so we have to look into this. So if we conclude this, the work of flexion is important. If you break it down, 30% is caused by the pulleys, about 30% is caused by edema and the extensor tendon working against the flexor tendon, and 30% is used up by joint stiffness and friction. Now, the friction I want to point out is the internal work of flexion, so the bulky tendon, the internal tendon swelling, repair thickness, and sutures. Now, if we work on these things by doing pulley venting, by doing edema control and correct positioning, and doing passive motion prior to active, we can lower the work of flexion. So that's good. Now I want to go on to, are we moving the right tendon? And this is something I've been talking about for quite a while. I think that profundus is really a problem. And this is really an important message for me. I think that based on the Strickland data, that you can see that the FDP is at a disadvantage. Up to 1.5 millimeter excursion is normal per 10 degrees of joint motion. But after a repair, that amount of excursion goes down with 65% at the DIP joint. So really, we should be focusing much more on the DIP and the FDP than on the PIP. And I would like to add up to that. If you see this picture on the left with the FDP repair distal to the split of the FDS, This is an extra pulley. You can't vent this pulley. This is a video of the FDS, the profundus is taken out, and you can see that the slips of the FDS are actually narrowing as you pull on the FDS tendon. So imagine that bulky repair going through these two slips. So if you start with flexion, should you start from the FDS, first pulling on the FDS, or should you start from the profundus, where you first have the profundus glide proximally, and then maybe use the FDS? I think the latter is the better. It's something to think about when you're working with a patient. So then when do we start to move? What is early active? Well, there's a simple picture for that one. If you wait, it's too late. You have to start between day 3 and 5, and this is all based on work of flexion with all the authors seen on the right. Then another thing I want to mention, if we want to record our results and we want to compare our outcomes, first of all, are we assessing the tendon function correctly? The other thing is, if we compare different methods in different articles, how can we be sure that we're comparing the same thing? So are these different methods that we have comparable? Hahn in 2016 actually looked at this in an article. And if you look on the left, that's from his article. This is a hand where you see the PIP joint going into hyperflexion at the PIP joint with very little DIP flexion. So it's more an intrinsic movement, maybe FDS. And we see a flexion contraction about 30 degrees. Now, if you use the Buck-Graham code for the result, it gives you an excellent result. But the palp to palm includes the MCP joint, so that masks the DIP deficit. And also, they say, the Buck-Graham code, the rules for Buck-Graham code are that the extension deficit of 30 degrees is an excellent result. Might not be so great. I don't think that is really a good result if you have such a flexion contracture, and I really question including the MCP in the flexion measurements. Because if you look at the Strickland original method, they do not include the MCP joint, and they say the result is poor for this same patient. And then if you look at the advanced, the later Strickland method, 1985, I have a little beef with that one too, because he expanded the range for excellent to good to 50 to 100%, and to me that is maybe a little bit too lenient, so you know my preference now. This is my idea of an excellent result. Early active motion. I saw the patient 6 to 8 times because I had a couple of phone visits, so I don't really count those. And this is a 10-week result, FTP, FDS, 5th digit, zone 2, 6 weeks early active splint with the wrist free from week 2. Now here, this is an excellent result. Full DIP flexion, no flexion contracture, return to work at week 10. So really, I think this is a better result, and this would be what we should be aiming for. So now if we're going to do a summary of the early active recommendations, based on all the evidence, we have to keep the work of flexion low, 1/3 of the fist, minimal angles, the wrist should not be in flexion, optimal positioning for the MCP and PIP-DIP joint when moving, and edema reduction and passive motion before you start moving. And I think the FTP is really important. And then again, patient understanding, the last one. The responsibility for both surgeon and therapist is important for good results. This responsibility was looked at actually in an article by Bigor in 2018, and 366 surgeons responded to a whole bunch of questions, 206 therapists responded, and about 75% of the surgeons thought that you should have at least a 4-strand repair, and 50% said active rehabilitation. The thing that struck me is that the therapists responded, lack of information from surgeons and therapists is really something that they have trouble with. And of them, 80% uses active protocols. So there's something we should work on, I think. And the authors concluded that there was one surgical approach. And the authors also concluded that there was too many different early active motion approaches. And I think that's kind of interesting, because is there really one surgical approach? If you look at a 4+ strand suture, you have so many different kinds of sutures. And if you have early active motion, you have a couple of different ways of moving them early active. So what is the big deal? I don't think that is so much of a problem. In fact, having these choices is not a problem. It should be a patient-centered decision-making process. So that's what we have to do. So we should have post-op guidelines, not protocols for surgeons or therapists. We should have a patient-centered approach. Varies depending on type of patient, type of injury, or type of repair. So it's sort of like, working with the patient to get the best result. We have choices to improve these outcomes based on the evidence, if you know the basics. You can use an optimal splint position, and you can change that. You can move actively, and you can use different ways. And you have to make sure the right tendon is moving. So the future of hand therapy forecast is pretty sunny. We get less protocols, or preferably no protocols, less splinting, and we should allow for a patient-centered approach for best results and use the creativity of therapists. So what is the future? I think we'll have really strong sutures, and they will withstand any load, so we can probably start right away. We might not even use splints anymore. If they're going to do a lot of pulley venting, then we might not have any work of flexion anymore. So for us as therapists, no splints, full loading of the tendon, no rehabilitation really after flexor tendon repair, so we're pretty much out of business. So I want to thank you for your attention. The email address is there to actually ask questions if you want to, and you can also ask for a PDF of my presentation, because I do like to share. Thank you.
Gwendolyn, thank you very much for that overview and the evidence-based ideas you've got. And we now go into more detailed stuff, listening to Zoe Cliff from the United Kingdom about the Manchester short splint. Please.
Well, thank you. Thank you for inviting me. Well, thank you to originally inviting Alison Rowe, who should take a lot of credit for the work done at Manchester. And thank you to all the previous presenters for essentially doing all of the scientific bit, so I don't have to do the complicated area. And Gwen for covering the entirety of my presentation and showing that actually there's no point in doing the short splint. But I'll talk through it anyway. So what I wanted to do is really, in short, give you some brief ideas about where the idea of the short splint came from, the work done at Manchester to develop this regime and why we did it, and then take you through the process so far. So I won't go over these in detail because the others have already covered them, but there was a feeling that the strength of repair and the techniques of repair were vastly changing pace and improving. And from a therapy point of view, we felt like we were lagging behind a little bit, still doing some of the original early active regimes on older surgical techniques. The biomechanical knowledge and the background of that covered by the other presenters had changed during that period of time, or the previous 2 decades, and our regime, again, hadn't changed a huge amount. Whereas if you looked at the history of extensor tendon repair and regime, it had changed hugely. The work of flexion principle, thanks Gwen, I don't have to cover that. We were looking at how our patients were presenting in the first week or 2 post-surgery and whether we were really getting the best out of our movement early, and then how that changed over the next 3 to 4 weeks. And we were concerned about the outcomes. So the Manchester short splint was originally designed on second stage tendon repair, so tendon grafts, and then moved to zone 1 and 2 tendon repairs. And in those particular zones, the consistent thing we were finding in those that didn't do well were fixed flexion deformities at the IP joints, predominantly the PIP joint, and then poor FDP or differential glide, but particularly, I would agree with the previous presenter, the FDP function wasn't necessarily the greatest focus and wasn't doing as well. So really, because everybody's presented all the science, what I can tell you is how a rehabilitation-based research process goes with flexor tendon. So the original work started by Fiona Peck, who many will have seen present in Delhi. She formally presented the first stage of the Manchester short splint, or the original ideas, in 2013 with audit results of some work that had already started at Manchester. And the original audit demonstrated that they were getting good results in terms of range of movement and that it was safe, effective practice. But it was felt that what we needed to do, particularly from a rehabilitation point of view, is strengthen that area of research and do prospective randomized controlled trial to really bolster our evidence for this. And that trial began in 2015, which, if you ask any of the, well, I was going to say, if you ask any of the team from Manchester who are here, it's just me from the rehab team. That feels like a very long time ago now. So for those of you that haven't seen Alison or Fiona present before or read any of the papers that have been published related to the audit, the regime in itself is, as Gwen was suggesting, really removal of the forearm component of the splint. There is still some blocking to wrist extension, but that's at roughly 45 degrees, and that relates to the work by Savage et al. The idea being that in that first initial 2 to 3 weeks, you're really concentrating on FDP glide and reducing the work of flexion. And that's done either by working a lot at passive range of movement, passive flexion at the start, concentrating on FDP glide with your active range of movement in an intrinsic minus position, making sure you control your edema as much as you can, and then also using tenodesis to help that patient glide through and reduce your work of flexion through your active regime element. I will add that that's, if people have tried to do that with some patients, your patients may be better than mine, but they often do really struggle to get the idea of tenodesis. So it often takes a little bit of practice. The other thing that we really work on is remembering that history of PIP joint flexion contracture is extending those IP joints out actively, and something that has changed within the regime from the early 2013 work is that we will add a short volar gutter splint to the affected digit early, even at week 1 post-surgery, if there's flexion deformity present. And the patient will wear that at night time. So the theme of the talk was in short. Well, that actual journey has not been short, and it continues. So between 2013, when the original work was presented, to now, people have adopted the Manchester short splint regime, and I'm sure there's many people in the room who are starting to use that technique with either all or some of their zone 1-2 flexor tendon repairs. The knowledge base continues to grow and change, and that's something that's been presented already by some of the other presenters today, and will continue on with Julie's work and the other 2 presenters later on, which will probably prove again that actually, although we're continuing with the randomized control trial, rehab is changing. And as Gwen said, it may be that we're getting to a stage where we're being even more what some people would call aggressive or proactive. So I know one of the things that Gwen wanted me desperately to present was the results. And at present, I can't. They're still ongoing. One of the consistent things we tend to find, certainly in the United Kingdom, if you're working with tendon repair and trauma-related patients, particularly in the Northwest and the Manchester area, they are very keen to return to work or not come to the clinic. So at the moment, data collection is slow, so that's a long period of time, March 2015 to now, and we've been able to include 45 patients in the trial, and at the moment we have 26 complete sets of data, and that is predominantly our patients stop coming in the first 2 to 3 weeks, and that's a huge area of dropout. What I can tell you is of those sets of data that we do have, we haven't had a single rupture. So we've proven that the surgical team at Manchester are excellent. Those of them that are here, congratulations. All your tendon repairs are intact. We've added the early extension splinting, and even with that, some people are nervous about doing that, but it hasn't changed our rupture rate. So the short-term future, I think the question's changing my original topic, the Manchester short splint, do we need to include the wrist? Probably the question that we're heading towards with some of the science that the others have presented is, when do we need a splint? Is it, as Jimbo Tang has started to present with his published articles, is it purely for protection? Is it a nighttime, busy places, and the rest of the time the patient is free if the tendon repairs are strong? Do we need a splint at all? That may be the next question, as Gwen has suggested. Having said that, one of the things that we're getting better at in rehabilitation is presenting our work at conferences such as this and publishing work that we've done. In the area of trauma, that's still difficult. So as we've started, we will be carrying on the Manchester short splint randomised control trial, and at some point, we will be able to present that work. Many of my colleagues at Manchester have hazarded a guess as why we have so much dropout. One of the pictures that Fiona often presents in the past is a picture of one of our flexor tendon patients at week 2 in his splint, complying with his therapy, building a wall outside the hand therapy unit. I don't have that picture to hand, but that is a genuine, true experience. I also see many of my patients putting their splint on in the car park that is right outside the windows of the hand therapy department before they then come to their appointment. So essentially, our work continues. It's safe. Is it effective? I can't tell you exactly yet. I can give you a few comments from patients that have voiced their opinion in our hand unit quite loudly. And that is when they're sat next to one of the patients that is in the trial and they say, oh, why has that person got a shorter splint than mine? Because I've been talking to him in the corridor and we've had the same injury. And we talk to them about the trial, and then they decide that actually they're not going to come back anyway, so they'll take whatever we'll give them. Or they decide that they're going to be too, as they put it, brave, and they want the longer splint to protect them. So that fits with your idea of no protocols and really talking through and being educated and educating your patient about the possible options. My email contact is up there, but essentially I'm presenting work that has taken many years by Fiona Peck and Alison Rowe, who can't be here because they're holidaying. They've retired. So they haven't been able to see the end of the randomised control trial, but this is essentially 10 to 15 years worth of their work to get to this point. So I congratulate them, and thank you.
Our next speaker is Julianne Howell. We've known each other for a long time, 35 years, and that's also her experience with the concept of relative motion. And she's been working with Dr. Merritt, who actually came up with the entire concept of relative motion. He's with us today. And relative motion for the flexor tendon is something brand new, and that's what she's going to present on.
So for some of you, it seems kind of awkward, at least for me, to be up on the stage talking about flexor tendons, because my topic is usually on the extensor side. But I'm really happy to take you back today. The relative motion concept is a 40-year-old concept plus, and I'd like to revisit that concept for you today. In the 1980s, Dr. Wendell Merritt proposed to us as graduate students that perhaps we could look at single muscles with multiple tendons, such as the EDC and the FDP, and apply a little bit more flexion at the involved MCP joint relative to the other digits, either an extension for relative motion extension or flexion for the FDP. With that position, we would impose the quadriga effect, which would allow us to range the fingers through a wide degree of motion without fear of injury. And this was the start of early active motion using a protective relative motion splint. In the 1980s, we launched the use of this concept with relative motion extension. It was known back then as the Wendell Merritt splint, the yoke splint, or more recently, the ICAM. They are all one and the same. This became a very hot topic and is used widely today. 40 years later, in a recent survey that Melissa Hirth and I and others have just completed, we have found that early active motion using the relative motion concept for extensors is the #1 used early active motion program internationally. However, at that time, we also looked at applying the same concept to repairs of the flexor tendons in zones 1 and 2, and Dr. Merritt proposed this. It was a long time ago, 40 years ago, but somehow in the future we thought this perhaps would develop, because the state of the art in the 1980s, as we're all remembering today, is it was two-strand repairs, meticulous repair with peripheral sutures, the sheath, both the FDP and FDS were all repaired. At that time, we were doing something that we thought was very unique, and that was early passive motion with Kleinert and Durand. So we put the pause button on relative motion with the flexor tendons because they were not ready for early active motion, and this was set on pause for 40 years. During this time period, however, surgery techniques advanced, as we've learned today so nicely. Four-strand core, Fian and Bouchain showed us with others that if we start moving these tendons early, we actually improve the qualities of the tendon themselves. And then the early active motion programs for therapy started to emerge with Small, Peck, Groton, Evans, Moyman, and Elliott, and others. As we get now into the present, we have really advanced technologically. We're up to 4 and 6+ core sutures, the freedom to resect the FDS if needed, if it's in the way, resecting pulleys so the tendon can glide, and perhaps no peripheral suture. There are many early active motion approaches at this point. And we've shown that early active motion is essential. It's not a, well, we'd like to maybe try this. It is something that needs to happen after a surgery of this type. So for this time period, now we're taking the pause button off and putting on the play button for relative motion flexion. And during this time, there have been some biomechanical studies that have kind of led to the proof of concept for relative motion flexion. The differential splint of Savage et al. Really replicates the relative motion flexion position you'll see here for the long finger. It's in the relatively flexed position compared to the adjacent digits. That these authors show that an increase in MP flexion would decrease the amount of force put out by the flexor digitorum profundus and would also decrease tendon excursion, protecting the tendon in that relatively flexed position. They found that the ideal position was 30 to 45 degrees of MP flexion in these normal patients. Later came along Chung et al. In 2014 and 2017. They actually replicated the model of Sharma that was kind of groundbreaking for relative motion extension and reproduced their technique in the flexor side of the hand. They used zone 3 FDP tendons because of the technical aspect. They looked at the amount of elongation in the intact and repaired tendons. They repaired them with simple sutures so they would rupture under tension, and they measured elongation. They found with the relative motion flexion splint that there was less tendon elongation, as one would expect, in both the repaired as well as the intact tendon. However, if there was no splint, that the repairs would gap, showing us that that position of relative flexion of the MP joint in the involved digit did, in fact, protect the repair. I had the good fortune about a year ago to meet Dr. Stephen Henry at a meeting in Austin, Texas, where he presented some of his case series that he had collected over the last 8 years. He was using relative motion flexion with his patients after zone 1 and 2 injury. And I'd like to present that information today. It is a retrospective, single-center, consecutive case study. There are 10 cases, zone 1 and 2 injuries. They were both simple and complex. 6 of these patients had sharp injuries, 2 ragged injuries. One was a stage 2 flexor reconstruction, and the other a type 4 FDP avulsion. So we had quite a variety of patients in this series. The surgery time was within 11 days. There was one surgeon who used a 4-strand Kessler-Pennington core suture with fiber wire. He did use a peripheral suture, and he resected the FDS and the pulleys as needed to allow excursion of that tendon. As far as the therapy details, most of the patients got to therapy within that first 5 to 6 days. There were some others that were out farther, up to about 20 days. The interesting fact here is that we had 5 therapists and 1 surgeon treating these patients. In the United States, sometimes patients do not have insurance for therapy. So Dr. Henry took on 2 patients to treat himself, and these are included in this result. There are no protocols. It is patient-centered. The splints that were used was a relative motion splint, flexion splint. The first 3 patients got a traditional flexor tendon splint with a wrist inflection. Remember, this started in 2008, so we were still putting the wrist inflection. As this program evolved, went to a prefab splint with the relative motion splint and the wrist in 20 degrees of extension. The relative difference in position between the MP joints of the involved digit were 30 to 40 degrees, so a bit more than we use with relative motion extension. The splint progression was the first 3 weeks the patients were asked to wear both splints. They were then able to remove the splints after 3 weeks to 6 weeks, wearing the relative motion flexion splint during the day. And overnight or for at-risk activities, they would wear both, hopefully. At 8 to 10 weeks, these 10 patients were discharged from their splint. The results. The sharp injuries had excellent results, graded by the original Strickland formula without the MP joint included. The ragged results had fair results. There were 2 of these. Grip strength returned within a reasonable condition of the dominant hand. Return to work, which is not often reported with these flexor tendon patients, was about 9.5 weeks. There were no ruptures. There were no PIP, flexion contractures, and there have been no secondary procedures. What we can do is compare to what's out there in the recent literature. We found, just as others have, that sharp injuries do better than ragged. We did have 2 patients fall away at 3 weeks from follow-up, so we really don't know their results. These were also sharp injuries, so we hope they're doing well. There were no ruptures. Geeson et al. In 2018 also reported no ruptures, but in others that are using early active motion in the recent literature, the rupture rate varies between 4 and 10%. We had similar total active motion good to excellent ratio as others. There were no PIP flexion contractures, as Zoe just presented to us from the Peck et al. Study. I have to say, after 40 years of experience with relative motion flexion splints, they're simple, they're practical, patients like them. It differs from other early active motions that say move it, but don't use it, sorry Dr. Long, to move it and progressively use it. So we're adding a little bit more motion than others. So what's in the future for relative motion with FDP zones 1 and 2 repairs? It's not a perfect program. I can already tell you things that I would like to see changed. But we really don't know until somebody starts using it and recording. We need larger multi-center prospective trials, clinical trials, of course. Please don't make me wait another 40 years to get the answer to this. So I'd be happy to answer any questions you have. My email address is there. I know Dr. Henry is here at the meeting, and he would love to share his results with you too. Thank you very much.
Thank you very much, Julie. Our next speaker is Tamara Howry. She works at the University Hospital in Zurich, Switzerland, and she's going to present her cross-sectional study where she compared early passive and early active motion and to see if there's a difference in return to work time.
It's an honor to present you our results about return to work after flexor tendon injury treated with the early passive motion protocol compared to the control active motion protocol. As we heard before, there are a lot of case studies reporting different protocols for the rehabilitation of flexor tendon injuries. As well, there are 4 literature reviews searching for the best protocol. All of them conclude there is no clear answer, no evidence. Further, there are 2 studies comparing an early passive motion with an early active motion protocol. There as well, after 12 weeks, both found no difference, but both had small numbers in the early active motion group. Except the work of Rue and colleagues, they found a difference after 4 weeks in the group of the control active motion protocol. This led the research group to the assumption of an early return to work for those patients, which would lead to a reduction of the cost. With this in mind, we defined the aim of the study to compare 2 protocols, early passive motion with control active motion, with the well-known outcome measure, total active motion, grip strength, and rupture rate. To broaden the view and as the aspect of work, we included the outcome measure time to return to work, as well as the number of therapy sessions for the costs. We included all patients treated in the University Hospital in Zurich between 2006 and 2016. The data was analyzed retrospectively. All patients older than 18 and with injuries in zone 1, 2, and 3 were included. Patients excluded were the patients after replantation and with adjusted collagenase diagnosis. The 2 protocols. As an early passive motion protocol, we used the modified Kleiner protocol, here on the left side in pink, where the injured finger is flexed with a rubber band for the first 3 weeks and the patient is allowed to extend the finger actively. As an early active motion protocol, we use the control active motion protocol, where the patient is allowed to actively flex the finger from the first week on. Therefore, it is a true active motion protocol. We included 88 patients in the EPM group and 80 patients in the CAM group. The groups were comparable in nearly all of the characteristics. In the EPM group, there were more zone 2 injuries, and in the CAM group, more zone 3 injuries. Because of the outcome measure, time to return to work, we distinguished further between blue-collar and white-collar workers. White-collar workers work in an office environment, and blue-collar workers are manual workers. In the following, I would like to highlight some of the results. White-collar workers treated with the CAM protocol had a significant earlier return to work with 24 days away from work compared to the EPM group with 42 days away from work. There was no difference between the 2 groups regarding full-time return to work. The CAM group returned after 89 days and the EPM group after 95 days. Regarding range of motion, there was a difference between the 2 groups. The CAM group had a TAM of 205 and the EPM group 183. The white-collar workers benefit further of the CAM with a TAM of 212 and the EPM group of 183. There was no difference in the blue-collar workers. The blue-collar workers with the CAM protocol had a TAM of 200 and in the EPM group 183. Another difference was found in the number of therapy sessions. White-collar workers treated with the CAM protocol needed 26 therapy sessions compared to the white-collar workers treated with the EPM protocol with 35 therapy sessions. To conclude, most of the patients benefit from the CAM protocol with a better TAM and the white-collar workers with an earlier return to work and fewer therapy sessions. Therefore, the CAM is more cost efficient because of the earlier return to work and the fewer therapy sessions. The cost of a flexor tendon injury can be reduced if the patients are treated with early active motion protocol. Thank you.
Thank you very much, Tamara. Our next speaker is Jonas Svingen. He is from Sweden, and he's going to present to us if a mobile application can improve adherence, self-efficacy, and range of motion after a flexor tendon repair.
So, thank you for this invitation. Adherence to home-based exercise program are considered an important part for reaching a successful outcome after flexor tendon repairs. However, this exercise program is a delicate balance between enough tendon motion to minimize adhesion and load low enough to prevent tendon ruptures. So, how can we help patients improve their adherence? The potential of a smartphone application in improving adherence have in previous research shown promising results in different conditions. So we developed a smartphone app specific for flexor tendon rehabilitation. Our hypotheses were that the intervention group that received the smartphone application would have significantly higher adherence, self-efficacy, and range of motion compared to the controlled group that only received standard rehabilitation. Patients who had been operated with a repair of a complete laceration of the FTP in zone 1 or 2, with or without injury to the FDS tendon were assessed for inclusion in the study. Criteria for exclusion were fracture, injury to the FPL, or extensor tendon. We assessed a total of 367 patients and randomized 101 patients to either control or intervention group. 13 patients in the intervention and 12 patients in the control group were lost to follow-up at 12 weeks. Both groups received standard rehabilitation. The protocol consisted of instruction of home exercise, information about the injury and restriction, all given on paper handouts. The home exercise program consisted of early active motion exercise within a dorsal cast or splint during the first 4 weeks. Range of motion and intensity was gradually increased in the same way for both groups. The number of exercise sessions and repetition a day was recommended after assessment of the participants' individual needs. For the intervention group, we tried to implement the cutting-edge research in behavior theories together with our clinical experience in a collaboration with the app manufacturing company, leaving our app including push notification as exercise reminder, video instruction on exercise, an exercise diary, motivational tips, and frequently asked questions. At baseline, there were no significant difference in demographic between the both groups. To answer our hypothesis, patients were assessed at baseline 2, 6, and 12 weeks after surgery. Physiotherapists rated patients' adherence through the sport injury adherence scale. The scale ranged from 3 to 15. To assess self-reported adherence, patients filled in a questionnaire on how many times a day they exercised and with how many repetitions. This was then compared with the prescribed exercise amount, making a percentage score. Self-efficacy was assessed with a questionnaire with 10 questions. The score ranged from 1 to 100. So the results. The intervention group had significantly higher self-reported frequency adherence compared to the control group at 6 weeks. There were no significant difference in any other measurements. So we have shown that a smartphone app can be effective in improving adherence to exercise frequency, but more research is needed on what underlying mechanisms can make an intervention successful in improving adherence in this patient's group. Some previous interesting research suggests that the ability of a smartphone app to assess range of motion and then give correcting feedback to patients can be a game changer in improving exercise. So, thank you.
Thank you very much. And now I would like to invite all the speakers here on the stage, because we still have half an hour almost, and we would like to open kind of panel discussion. And of course, if somebody from the audience thinks that have interesting questions, I would like, more than welcome to ask them. I will start with the first question to all the speakers, and we have heard about biology, we have heard about different suture techniques, we've heard about different rehabilitation protocols, we've heard about the role of informatics and applications in better outcome of our patients, but we didn't heard about something which maybe is the future. What is your opinion about the two questions I would like to put? One is the glue, the role and importance of the glue in tendon surgery. And the other is the material which will prevent adhesions, the gliding, improving gliding, and some artificial material. What do you think about these two possibilities?
I think one of the, is this on? Okay. I think one of the therapists said that the surgeons will put the therapists out of business pretty soon. I don't think that's going to happen. You know, many of us have worked on tendon tissue engineering, biology for a number of years, but still it's a very tight space, and there's only so much we can do. So I think the big revolution has been 4 strands or more in wide awake hand surgery, and then we've passed on a little bit of a wiggle room to you guys to begin to do all the active protocols. So I think it's going to be quite some time before therapists go away.
Hopefully, yes, because I'm still young and I love my job. Yeah, I think the essential part is really the early active motion, and the progress will be that we will be more working without splints and more active motion, and the patient is allowed to do more. That will be the essential part.
In terms of substances that improve gliding, I think that we may win there, but I think it's pretty hard to improve on 2 billion years of evolution. In terms of glue, to me, glue is like sutures. All of the different sutures and glue are just all different ways of putting the tendon together. I don't think that the answer is in the different sutures. We've been focused way too long and done way too much research on the number of sutures, the types of sutures, the types of knots. That's not where the Holy Grail is. We're looking in the wrong foxhole. The ruptures are about the tendon bunching in the suture, in my view, with the forces of active movement. And as long as we got no gapping with a full fist on Monday, then I know on Friday, if we do up to half a fist, we're not going to gap and we're not going to rupture, whether it's glue or whatever repair you have.
We're trying to beat evolution in our labs, and it's not proving to be too successful. We spent a lot of money on different innovations in terms of biomaterials, different suturing techniques, and really, I think James is absolutely right. The focus should be on those little marginal gains that you can get with rehab. In terms of outcomes, you look at Jimbo Tang's results, no ruptures, early active motion, great results. We need to emulate that in all the departments around the world. It's not just one shining beacon in Nantong that gets these great results. We've got to really kind of disseminate that learning and show good quality evidence. That's what we're able to achieve.
I believe that I've been freed up by being able to see what happens in surgery by the Wallant surgery. And it's given me the confidence to do what I know I should have been doing in the beginning, is moving these patients. And just to be able to see it frees me up to center on the patient and their particular needs. And I think overall that will help our end results.
I agree. I think the probably the essential element for improving gliding is us. So I will provide a role for the younger members of the panel to keep going. Probably the thing that we haven't had chance to speak about in the session is our role as rehabilitation practitioners to encourage our patients and empower them, so you have a portion of patients with a flexor tendon repair who will be absolutely frightened to death and scared to move, and changing their rehabilitation to, it may not be exercise or pure exercise is their thing, and a lot of the panel talking about just using your hand automatically makes it feel more normal. And then there's the other portion of patients, particularly relevant in Manchester, who aren't frightened at all and need no encouragement to use it, and giving them the feeling of understanding that and placing care in their repair. So it's probably a different emphasis of rehabilitation and really empowering your patients to do things that are going to allow those tendons to glide.
I think it's not possible to be better than the nature for tendon healing. Nature is the absolute best. It took many million years to be such a perfect healing, but we can help to heal. And I don't believe in glue, because the blood supply must go into the tendon, and what we can do to help the nature is to have movement on the tendon. If the tendon is moving more than 5 millimeters, we have no adhesions. And I think we need such special things to improve and to help the nature.
Well, I'm not going to be saying anything new here. I think by early active motion, we made the whole gliding materials that we're adding to it obsolete. So the early active motion is the trick, but I think I'm agreeing with Zoe a lot that we shouldn't patient their hand and know what they're allowed to do. So patient education is probably, to me, really important to get them over their fear or slow them down and teach them why they should move, and then they will be more responsible about it. So that would be my trick to that one.
I think as a hand therapist, it's important to, when the suture strength and surgery improves, it's important for us to keep up with our research and to improve our rehabilitation protocols to the new what do you say, strength that are allowed for the tendon.
Are there any questions from the audience? If not, I would have two questions as well. I think from the surgical side, as I understand all of you, we agree that we want to have a strong suture with as little resistance as possible. And so one question, do you have any idea how to improve it any more than by the principles we've got now? And the second is, and Gwendolyn, I really, really liked your talk, how much individualization of the treatment can we achieve not living in the perfect world? Meaning, do we see a chance that we don't need any splints, because if we have the perfect patient, the perfect doctor, the perfect therapist, we don't need any support, because we would be able to treat them free of everything. So these two questions: can we do something to improve our technique surgically? And what can we do to get that much individualization?
Thank you, Jörg. Regarding technique, I guarantee everyone here in this panel and the audience can show me a beautiful flexor tendon repair that they've done. The challenge is to make an effect on all the other tendon repairs that are out there, because I know they look like this, right?
they're all fraying and gapping and all that. So how to improve that? And that's why I like using an epitendinous first. I like controlling the fraying and then adding the stronger core tendons. That's the way I teach it. But somehow we have to be able to make an effect on the rest of the world. Don, how about you? How about what are the tricks that you teach your trainees? I know you can do it. You know I can do it. But how about your trainees, your junior residents?
Yeah. I think just telling them that I want that thing to not go anywhere. Like, I want a good, darn solid repair, and I don't care if it's not absolutely pretty. I just care that it's not going to come apart, because it's going to move in the zones that we've vented the pulley. So that's what I teach the residents, and I think that's what is 1987, or in 2017 paper. And I really think that that 2017 clinics paper should be given to all residents. I really do. I think that'll help a lot. But I think to also answer your question, what can we do better? You know, I think Julie's and Wendell's idea. Microphone. Yeah.
There you go.
Thank you. I think that Julie and Wendell's idea of the relative motion flexion splint for flexor tendon repair may be the simplest, best thing to do. I know we've done a couple. Amanda's here. I know that she's done at least a couple of those, and we've not had any trouble with them. And, you know, I think that it takes the brains out of it. You know, they can just wear the splint. And I think that that might be a good thing to do. I would encourage people to at least try that. I certainly have no fear of trying it. If I got a relative motion flexion splint on and I give people good advice, I think that they're going to not rupture. I really do, especially with good solid repairs. So I think that's important. And the idea of going without a splint, whenever I do give people a splint, like for simple hand fractures, I tell them that this splint is a Hollywood splint. It does absolutely nothing. It does absolutely nothing. It's just there for visual effects. And the reason that we give them that is because they're human. So they're going to forget. And they're going to go to use their hand either to pull up their pants after they go to the bathroom, or to eat their supper, or to brush their teeth. And if they have a splint, it's going to remind them that they got a bobo and that they can't do that stuff. And so a splint does have value. I think that humans are humans, and if you give them absolutely no splint, they're going to get into trouble. They're a little bit like teenagers. They just can't help it.
So one of the videos that I've taken out of the talk actually looks at all the different types of tendon repairs, not all 107 tendon repairs that are reported in the literature, but quite a large number of the popular ones, so 4-strand repairs and 6-strand repairs. And if they're made of all the same material and they're all doing 1 centimeter bites, they all gap. They all gap at about 30 newtons of force. So really, what you're trying to do is manipulate your therapy so that you do not gap. And I think the best way to do that is with Don's technique of intraoperative assessment of that repair. If you can guarantee that it's not gapping on the table at that point with that patient, then you're probably going to be okay when it comes to the repair. Once you've got gapping, that's it. The tendon ends will, the suture will effectively deform and rupture. Going on to the rehab side, I think the individualized approach to each patient is the key. So we look at major lower limb trauma, and we've got this program where you strategically run an MDT with a surgeon involved, a physiotherapist involved, and you target the individual loss within the hand function. And the results you get from that are far greater than a very standardized protocol. I think we need to move away from inflexible protocols and actually do individualized teaching.
All right, to answer your question, Jörg, I think that we as therapists, we have to teach not to work with protocols, like you were saying. We should get away from protocols. We should teach them concepts, like I was presenting in my talk. And if you understand the concept of anatomy and physiology and wound healing, if you understand those things, you don't have to have a protocol, because you look at the patient, you observe the patient, how they move, you know what's going on, and then you know what to do. Now, if the therapists cannot come to these conferences, well, then we luckily now have live streaming, so everybody can look at it. But there's also a role for surgeons there. I think if you are a surgeon and living in an area where you have long distances between the surgery setting and the therapist, that it can be up to a surgeon to refer to a patient to a therapist. And if you do that more often, try to teach these therapists about the concepts and not ask for the protocol. So don't say, I want early active motion protocol. Tell them or talk with them and figure out what you want to do. And then you need all those different things that I presented to be able to talk about these individual treatments. So that's my point of view. I think you should not do protocols. I really hate the word protocol. In my opinion, that's not the way to treat. We should teach each other and surgeons and therapists and communicate about it. So that would be my way to treat the world. And I shouldn't forget that using modern technology, I mean, I'm not good at it, but I have been using it, but I think that that's a really good thing to start using our mobile phones and using WhatsApp. And I have been calling with patients and sending little videos and talking about exercise. I would ask them to send it to me when they were exercising, so I could observe how they were moving at home. So that did help. So I think the mobile app is definitely going to help us.
If I could just add to what Gwen says, I think we need for therapists a similar program to how you teach suturing techniques for therapists on how to observe motion, what you're looking for. So we need us old folks to be mentoring more, because it's not something that you just know coming out of school. It's something that you have to see, learn, taste, feel, just like suturing techniques. It's not a given that a therapist can do that.
So in conclusion, I would like to ask all the speakers, can we agree, because a lot of audience is here, that at this moment, our idea about tendon repair is not a question of technique, it's not a question of protocol, but more, it's not about how many strands, it's 4 or 6 or 8 or 12, or how many knots to put or what kind of splint to use, but it's the understanding of biology, the understanding of healing, and that's more important than the technique itself, understanding the psychology of the patient. And I think that this is what we can agree that is the most important. Do you agree with me?
Yeah, I would like to add to that I think that observation, how people move, is also one of the most important things, because if they move with an intrinsic motion, then they're not going to move their extrinsic flexors. So you really have to look at how they move and add that to your list of things. So that would be my addition to. Which way? Down?
Yeah, I'd like to just underline a point that I think is critical. When I do a flexor tendon repair, I'm not all that fast. I'm not a rapid great surgeon. I'm just a normal guy. And it takes me an hour and a half to 2 hours to do it well. And that is captive time that I have with that patient. And I'm not always focused on the little fine stuff. I'm suturing skin. I'm doing things that are pretty easy to do. That's time that the patient has nothing else to do but listen to me, whether they want to or not. It's like when you got your teenager caught in the corner there and you're just explaining life to him, whether he wants to or not. And it's a great time to find out about the patient and what they're doing. And it's a great time to guide them, because people need guidance. You know, when you get a flexor tendon laceration, it totally changes your life for a month, like major change. And who better to guide them but us who see them and know what kind of trouble they can get into, and help them out with that, with intraoperative education. And that's something you can't do with sedation, which is part of the reason that I'm really not fond of sedation, because they can't remember anything you tell them. But if you have a well-educated patient who walks out of the room, who knows that they have to keep their hand up higher than their heart and not move it for the first 2 or 3 days so they don't get blood in the wound, which turns to scar, like what Jason was telling us, and it's dry as a chip and you don't have tourniquet let down so you don't have all that blood there, you really have very little swelling. They know how to take their painkillers. They come back 3 days later and they've not been walking around like that taking morphine. And those patients are educated. And I really want to stress the intraoperative education part because I really think of all the things that I've done over the years, it's that piece that has decreased my complication rate and improved my results the best.
Zolt, I think you summarized it very well. We've gone away from the term protocol. Protocol is a bad word now because we don't know what week we're in. But I think what's important that we're all on the same team, that we're all playing from the same playbook. And like a soccer game or something else, you can adjust depending on the patient. So that the patient, the surgeon, and the therapist on the same team playing from the same playbook will give you the best result. It's a beautiful game.
May I draw a little conclusion to this very, very important session on flexor tendons? So we have learned that the kind of injury and the kind of suture we are able to put in that tendon in that situation is critical for the resistance of our suture. So we have to transport that information. So this is what exactly you said just now. Critical is to get the right information from the doctor who's done the suture to the therapist who is doing the therapy. The next thing is our patient has to understand the biology and what we've done. And if we are able to transport that information from the doctor's side as well as from the therapeutic side, that really is treating the patients over weeks afterwards, we don't need any protocols. So in the end, we really have to ask ourselves, do we just need more time for our patients to get better results than more theoretical concepts? And I want to close that round. Thank all of you experts for your expertise and for teaching us. And I hope all of you could take some notice of it and take some message home for the patients with flexor tendon repairs. Thank you.